Artificial intelligence and medicine, how it's being used right now. We learn how AI could impact your next mammogram or doctor's visit. Good morning, I'm Alexis Del Cid in for Jessica Lovell. Welcome to the Morning Medical Update. Artificial intelligence isn't new, but it is certainly in the news a lot these days. And today we're exploring how AI is already being used by providers here at the University of Kansas Health System. Tony Jenkins is the Assistant Director of IT Initiatives here at the health system. He joins us this morning to help explain the systems that you might see your doctor using at your next appointment. But first, AI is already being used at the health system to help detect breast cancer. Dr. Annalisa Winblad is a breast imaging specialist and the Division Director of Breast Imaging at the University of Kansas Cancer Center. She uses artificial intelligence to help identify trends and risks in her patients.
Ultimately, our goal for these tools in breast imaging is for these tools to look at our mammograms and assess not only if there's cancer present, but identify patterns that are more commonly going to be cancer in the future. This patient has dense breast tissue. You can see this patient's cancer is more difficult to find. So as we go through these images, we're comparing to prior mammograms, and I also have 3D technology that helps me find abnormalities in the breast. We can then pull up our Volpara density scorecard as well as our Transpara report. This is a case where it did a really great job and accurately identify this, very subtle cancer that was hiding amongst all of that dense breast tissue. The software itself can provide imaging information about areas necessary for improvement. We make sure our technologists are given wonderful feedback that they're continuing to perform high quality images so that our radiologists can actually find the cancers.
All of our images are actually scored through the AI system. So every single image that's taken is given a score of perfect, good, moderate, or inadequate. And so from that, we can identify trends. Are we missing parts of the breast? Did we get far back in the breast? As mammographers, that's what we're trained to look for. It's like a personal coach for each tech.
That AI is not going to replace physicians, but physicians certainly are going to have to get comfortable with using AI to perform their job better.
We're speaking live with Dr. Winblad right now. Dr. Winblad is at our Indian Creek location on a gorgeous morning, just beautiful out there. Dr. Winblad, you told us that this technology is super helpful, but it's not perfect. What are all the positives to having this resource?
You're right, AI tools are definitely not perfect, but they are another tool in our toolbox. And some of these tools can help us provide more efficient care and more effective care for some of the tasks that we perform so that we as physicians can spend our time focused on doing what we do best, and that's taking care of patients.
All the AI information is provided to you at the end of the exam. That's intentional. Can you explain why?
Yeah, you're correct. That's intentional. When we implement AI tools and healthcare for patients, it's not only important that we validate these tools for accuracy and safety, but we also don't want to introduce any potential bias, especially before these tools are validated on large, diverse populations. So we as physicians, it's really important that we evaluate these AI tools and implement them appropriately and correctly for our patients. And as a radiologist looking at images, we have chosen to do that at the end of our exam so that we don't introduce bias.
It's interesting. And we know imaging is crucial in detecting cancer. How does the AI guide your technologists?
So our mammogram positioning and even compression from a mammogram are critical in detecting breast cancer. As a radiologist, I cannot find the breast cancer if I don't have high quality images that cover all of the patient's breast tissue. So these advanced AI tools, such as the tools we have at KU, really provide our technologists with great feedback, great education, so that they continue to operate at their highest level of abilities and perform the best images so that we can make the best diagnosis.
So when it comes to breast tissue, so many women are now hearing that they have dense breasts. What does it mean when you're told you have dense breasts?
breast tissue can either be dense or not dense. If a patient has dense breast tissue, this means that they have more fibroglandular tissue in the breast relative to fatty tissue in the breast. Having dense breast tissue is common, it's normal, and it's important for two reasons. Number one, if you have dense breast tissue, it becomes harder for the radiologist to find the cancer on the mammogram. And number two, patients with dense breast tissue have a higher lifetime risk for developing breast cancer. So for patients with dense breast tissue, we offer additional screening exams such as ultrasound or MRI or contrast-enhanced mammography in addition to the regular routine screening mammogram.
Okay, I want to bring Tony into this discussion now because Tony, people hear AI, they think Chat GPT. A lot of people. There's a lot of concern over Chat GPT and other generative AI tools, right? But they're just the newest tools under the big umbrella of AI. So can you explain how you define AI and its role here in healthcare?
Absolutely. So AI is really just the ability to imitate human behavior and intelligence by very capable machines. And these machines are using information that has been collected through the course of our patient care, through the course of our administrative activities, and it's allowing us to analyze vast amounts of data and find patterns that maybe previously were harder to detect by humans just by looking at all of the data on a screen. So ChatGPT is just a way that a human can interact with some of these tools. It creates some content for you. That's kind of the easiest way of looking at it, through prompting, through questions, through natural language that you and I are having right now. We would be able to go and have those conversations. But you're right, it is just kind of one tool that's now available. We've been setting the foundation here in healthcare to leverage AI for years.
When you say it's an extra tool, that's reassuring to patients who are wondering, how is AI affecting my healthcare? So you're saying out of this big toolbox, it's just one more trick that everyone has up their sleeve medically.
Correct.
To help diagnose.
And it's allowing, as we heard Dr. Winblad say, it's allowing for more meaningful interactions between the clinician and the patient, where we're kind of removing, with some of the technology, some of the administrative burden that they may have. There's hundreds of use cases, and we have just started to begin to scratch the surface of how we can leverage this technology going forward.
So is it going to help then the doctors spend more time with their actual patient care?
Absolutely. So that is the goal. The entire goal of leveraging AI or any technology that we have available is to use the best in class to be able to allow our clinicians more time with patients to do the things that they want to do. They want to spend time with patients. Right. You know, writing notes is necessary, it's important, but we also need to be able to free up more of their time to also have a personal life so that they can be rested and able to take care of their patients.
Or just rest.
Yes.
And unplug for a little bit. There's always a concern when we talk about AI and technology that it's going to replace someone, that it's going to lead to job losses, unemployment, unfilled jobs. From your perspective of AI, is it coming to replace people in the medical field?
No. So today, upskilling, allowing our clinicians to operate at the top of their license is really what we're using AI for. So it's going to augment the skills that they learn and that they provide, and it's going to allow us to, again, perform our tasks maybe a little bit more efficiently, but it's also going to allow us to, again, focus on what is truly most important, and that's that relationship.
So if you could talk to a patient out there who's watching this and they're still skeptical, they don't trust it, what would you say?
You know, that's normal and that's natural. So there is a learning curve to leveraging technology and to understanding all of how it can operate. But really, to demystify it, truly it's just using technology that is now available, and it's going to allow us to operate again at a higher efficiency and capacity, and it's going to allow us to take care of each of you, but really take an opportunity to learn, be aware. Ask your medical care team as you're in clinic and talk to them about what tools they're leveraging, and just kind of have that dialogue.
There is another layer to this, which is ethics. We know there are lots of things we can do with AI technology. How do you decide what you should do with AI?
You know, it starts by having strong values. And here at the health system, that is the core of who we are, is to ensure that the things that we leverage, whether it's tools, whether it's processes, that all of it revolves around who we are as a health system, and that's putting patients, you first.
So where do you see it? Oh, sorry, go on. You were going to say something else.
So as we start to leverage AI, it is going to be important that we understand that we have partnerships that exist throughout our community. We are working with those who are grappling with those tough things around, the transparency of how the tools came to the decisions and how our clinicians are leveraging that to, I think, Dr. Winblad, you mentioned let's make sure that we aren't exacerbating any additional sort of issues that we have related to bias. And so I really appreciated your thoughts, kind of adding that in, that we have partnerships with community providers where we are grappling with those issues. The Center for Practical Bioethics is a local agency here in the community that we have partnered with. And it's a great relationship where we're still learning, they're learning, and together we're going to make the best that we can for our patients.
Well, I love what Dr. Winblad said about how she doesn't want to be biased by the AI. She wants to use it as a tool for her expertise, right, Dr. Winblad?
Absolutely.
So how do you see, Tony, AI being used in the future? If you have a crystal ball, how do you see it being used here?
As we've mentioned several times now on the program, it is just a new tool that's available in the toolkit for our providers to be able to leverage. And as we continue to move forward, there are hundreds of use cases that others who have gone before us have said, this is a good way to start. We're going to be looking at leveraging maybe some of those more things that, again, we have to do. We have to take care of our patients, and we want to take care of our patients, but sometimes those notes, again, I mentioned that already, aren't the best way that we want to be leveraging our time. And so dictation is going to be one of those areas that is definitely blossoming, where we can have these systems listening to those conversations and providing a recap of those notes, and then allowing the clinician to come behind and say, yeah, that's exactly what was talked about and happened, and reformat. Keeping the human in the loop is very important. And so I think that's where we're going to see the biggest focus in the near term, is on how can we free up time to be spent in more meaningful interactions, less time spent on some of those tedious but necessary activities.
Yeah, instead of hours and hours of taking notes after you're done treating patients, you can go home and rest, and you maybe treat more patients if there's an emergency, or if someone calls you, you're rested the next day. We already have questions coming in about this topic. It's a hot one. So if you want to connect with us in real time, you can join us on YouTube, Facebook. You can email the Medical News Network, send your questions and comments in. All that information is right there on your screen. Women with dense breast tissue are 4 to 5 times more likely to get breast cancer than women with fatty breasts. And high breast density is very common. As Dr. Winblad was saying, in the U.S., 40 to 50% of women over the age of 40 have dense breasts and should be getting mammograms at least, and perhaps some additional screenings. But the mammogram doesn't need to be a chore. In fact, I met up with a group of gal pals who are taking their health into their own hands, and they're having fun along the way.
We're going to go to Crate and Barrel.
I have some really great friends.
Cocktails at the Phoenix at 4, and then dinner at the Faux Frog at 5:30. We're coming from Manhattan, Kansas. It takes 2 hours to get here, and it's much more fun to do it as a group.
Everybody thumbs up. There we go.
These 6 women do nearly everything together.
We're planning on a Saturday brunch and sunfish sailing.
So an annual trip to Kansas City makes sense, but not for the reason you might think. It was a medical scare with one friend in the group that prompted this regular road trip to the University of Kansas Cancer Center.
I felt a lump on my breast, and I went to my local doctor, and it did seem to be questionable, so they ran some additional tests. They reported that I had a 1-centimeter tumor.
But before Barbara Gatewood started treatment, a friend suggested a second opinion. advice she says saved her life.
Go to KU and get a second opinion. It's a premier place for breast cancer diagnosis and research. So I came here and the results came back that I really had an 8-centimeter tumor and it was stage 3 breast cancer.
Barbara went through chemotherapy, radiation, a double mastectomy, and reconstruction surgeries, all at the cancer center. After witnessing the care Barbara received, her 5 friends decided the 2-hour drive from Manhattan for an annual screening was well worth the trip.
It's so easy to be misdiagnosed in some of the local hospitals that don't have the expertise that they do at the cancer center.
All the people that are working here, so that not only are they assuring that you're getting the best care and the best interpretations, the best readings of the mammograms, but that everyone's always striving to do a little bit better. And I think that's important to us.
Important enough to hold each other accountable to get a mammogram and have a little fun.
Have a little mammo fun is what we're going to call it.
Dr. Winblad, I have to get your thoughts on this because rarely do you, well, I'd never heard the phrase mammo fun before, but mammograms shouldn't be scary. So what's your take, I imagine you love it, on this group of women that make mammograms such a priority?
I love this story. I commend this group of women for taking charge of their health, holding each other accountable, and supporting each other to make this a fun event and not a scary event. So I love it.
Can you go over the guidelines for people watching as far as what age do you start getting mammograms and how often?
Average risk women should have their first mammogram at age 40 and should have a mammogram every year. This recommendation saves the most lives and gives us the best opportunity to detect breast cancer when it's small and treatable. And for all women age 25 and older, you should talk with your doctor about your breast cancer risk factors to determine if you need to start screening earlier than age 40.
We talked about mammograms being a great cancer screening tool. They're just one of the tools you have. Can you help us understand the others and when an ultrasound might make sense?
You're correct. There are several tools for breast cancer screening. We advocate for routine annual screening mammogram for all patients aged 40 and older, but there are patients that have recommendations for additional screening tests. And those are our patients with dense breast tissue or our patients that are higher than average risk for breast cancer. For these two groups of patients, we have additional screening tests that may be indicated, and those are ultrasound, breast MRI, contrast enhanced mammography. At KU, we offer a wide variety of supplemental screening tools for patients with both dense breast tissue and high risk for breast cancer.
So I actually have a question for you with dense breast tissue. I always need to get that second screening. Should you schedule them both on the same day if you know going into it, or should you do them 6 months apart so then you're getting 2 screenings a year?
That's a fantastic question, and we have patients choose both of those screening kind of regimens. So it's completely satisfactory to do either or, whatever is going to be best for a patient's schedule so that they come in and get that additional screening. That's the most important, that it gets done and that they're able to fit that into their schedule. For some patients, it's easier for them to come and do both at the same time, and some patients prefer to come every 6 months.
Gotcha. So Tony, when it comes to the technology, I want to talk about this study that was published in the Radiological Society of North America. It found using AI reduced the overall workload of breast oncologists, radiologists, while improving the screening, which is what we talked about. Do you see areas of improvement for AI in actually detecting the breast cancer here at the health system?
Absolutely. It's just, we're just touching the tip of the iceberg when it comes to the possibilities. You know, radiology has been a scene where AI has been really at the roots of moving forward and growing. And so here we have an opportunity to, again, leverage what's available. And we are only just, again, starting to see the very beginning of that.
We have some questions coming in from our viewers, so let's get to those. Yen Liang wants to know, He writes, there's a new type of 3D mammography. Does this method provide clearer imaging and cause less discomfort for women during the examination? Dr. Winblad?
3D imaging has actually been used for several years, and we at KU perform 3D imaging on all of our mammograms. It's the best technology. It does allow us as radiologists to detect more breast cancers, and it also allows us to prevent additional imaging when a patient's breast tissue is normal. So 3D is our best technology for mammograms, and we recommend that technology for all of our patients undergoing mammography.
Stu has a question. Stu, and I love that guys are sending in these questions about breast cancer screenings, because they are an active role in helping their partners not get breast cancer or detect it. Stu wants to know, when you're reading a mammogram, how helpful is it to have a previous mammogram to compare with?
It is incredibly helpful, and it's critical that we have prior mammograms if they are available. In fact, it's actually a recommendation and guideline that as breast radiologists, if I see a mammogram and the patient has priors that are performed at an external facility, it's actually my job to make sure that we request those and obtain those before providing a final interpretation, because it's incredibly important. It prevents us from calling the patient back for more imaging when it's not necessary, but it also helps us detect those very subtle changes that we can see with some breast cancers. So priors are very important. We ask for those priors all the time if the patient has them elsewhere.
Jeremy has a question about dense breast tissue. Jeremy wants to know, is dense breast tissue becoming more common, or are we just average people becoming more aware of it?
I think we're just becoming more aware of it. In fact, very recently in September, dense breast law went into effect, and it requires all mammography facilities to notify patients of their breast density. So we are just becoming more aware of it. Our patients are now aware of their breast density. They're asking more questions. Facilities are offering more supplemental imaging studies, and I think we're hearing about it more on social media and the news and in our communities. So we still are, it's always been around 40 to 50% of patients of screening age have dense breast tissue, and now everyone's going to be aware of it.
Jill has an excellent question. She wants to know if it's possible for one person to have both dense and fatty breasts, or is it one or the other?
So, great question. Most patients have areas of fatty tissue in their breasts and areas of fibroglandular dense tissue in their breasts, and the most important factor for the radiologist in assigning breast density is the relative amount of that dense breast tissue comparative to the fatty tissue. And then we give one density assignment, so the patient will either be given a dense breast tissue assignment or an assessment that's not dense.
For today's takeaways, Dr. Winblad, what do you want people watching to know? What's the most important thing?
It's October, it's Breast Cancer Awareness Month. The most important message from me is to make sure you're up to date on all of your cancer screening studies. These screening exams help physicians detect cancer at the earliest stage when cancer is treatable. For breast cancer screening, start screening at age 40 and get a screening mammogram every year. If you're 25 or older, talk with your doctor about cancer risk factors. This will help your doctor determine if you need additional screening studies or if you need to start screening before age 40.
Dr. Winblad, I actually have one more question for you. Becca wants to know, when you're at your appointment, how do you know that AI is being used? Do you go in and ask, or will you actually be able to see it being used?
You can ask. So ask your medical team, are you using any software tools to help you provide better care for their patients? And they're oftentimes more than happy to share the very wonderful tools they're using in their practice to make care better for our patients, to make it more effective, provide better service, provide faster service. So every physician team is probably using a different tool that helps them in their practice. And breast imaging, we're using very different tools than another medical team may use. So ask your medical team.
Tony, what's the one thing you want our viewers to take away from this?
AI there's a lot of hype. And there's a lot of people who are talking about AI. And really the thing that comes down is, again, it's a technology. It's going to allow us, as Dr. Winblad said, to operate more efficiently. It's going to allow us to provide better care. It's going to increase communication. And again, we've been using technology. Really, nothing is new. The care that we provide here at the health system has always had behind it a supporting cast of folks and software and tools that are allowing us to provide that best level of care. So if you have questions, please ask. Talk to your medical team, and they will make sure that people are comfortable with how we're providing care, the tools that we are leveraging, and be able to explain the context, the why. Why are we doing what we're doing? And we'd be happy to explain. And
thanks for being on and explaining it to us in non-technical terms so that we can all understand what's happening, because a lot of our viewers aren't IT technical experts and they're not doctors. So we appreciate that, you and Dr. Winblad, for your time this morning. And thank you to our guests for joining the conversation. We're so happy we had you with us today. We'll see you right back here tomorrow morning.
Diet and exercise or bariatric surgery, different ways to fight type 2 diabetes, but which delivers better long-term results? I'm Jessica Lovell on the next Open Mics with Dr. Stites. A 12-year study offers new insight. Hear from doctors and a patient weighing the pros and cons. Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.